Assalamu alaikum wa rahmatullah. To continue from the last lecture, we talk about the blood donation procedure, and we talk about adverse reactions that may be or may happen with the donor during the donation process. One of these reactions is a grade, or it is categorized as grade 1 and grade 2 and grade 3. Grade 1 and grade 2 is mild reactions. Symptoms may include sweating, loss of pallor, weakness, nausea, dizziness. And all these things can be categorized as grade 1. But when we talk about rapid breathing, it will be categorized as grade 2, and it will include fainting. What we can do, the first thing to do is to stop donation. Remove the needle, elevate feet above head, cold compresses on neck and head. Breathe into a paper bag. These things, all these things should be taken with the donor. So we have to stop the donation process of the donor. We have to remove the needle from the donor and elevate feet above head. And we have to put cold compresses on neck and head. And we have to give the donor a paper bag to breathe in it. And all these things may stop all the symptoms that may be happened with the donor, and we can check the status of the donor after that. And we have to record all the information that has been happened, or all the occurrence things that happened on the donor record. So we have to record these situations. There is another type of adverse reactions that could happen also, which we categorize as grade 3 reactions. Grade 3 reactions include the grade 1 and the grade 2 reactions, plus involuntary muscle contractions. So the donor may have involuntary muscle contractions, may suspended his respiration, and it may happen that pupils that are dilated and fixed, excessive salivation and convulsions. All these things, or all these reactions, are categorized as grade 3. So we have to know that if the donor has these symptoms, his situation is not very good, and we have to take an advanced response. So we have to protect the donor because he has a convulsion, or maybe he has a dilation of his pupils, eyes, and maybe he has a salivation and convulsions. So you have to be sure that the airway of the donor is open. Seek for immediate medical attention. So we have to ask for immediate medical attention from the physician or doctors. And we have to notify the physician to check the patient, the donor, and he can be like treated according to these symptoms. And all information should be included in the donor record as well. We have to move to another part of our introduction into blood components. The first is the whole blood. Whole blood, we are talking about all components of blood in one bag. And the contents of whole blood is everything is present in the blood, such as RBCs, plasma, and the RBCs can be measured according to the percentage of RBCs to plasma. We call it hematocrit, which should be around 35%. White blood cells and platelets not viable after 24 hours of donation. Clotting factor significant decrease after 2 days of donation. So when we are talking about whole blood, we are talking about the blood that have RBCs, plasma, white blood cells, platelets, clotting factors, proteins, antibodies. All components of whole blood should be present in the whole blood. The shelf life is like an important statement which is related to the expiration date of the whole blood. So we have to record the date of donation, and we have to record the date of expiration date according to the anticoagulant which is present and in the donation bag. And we talk about these types of anticoagulants, which we say that the maximum shelf life of a anticoagulants presence or the whole blood or the blood which is present in the anticoagulant is 35 days. And we can extend it to 45 days according to the components of the anticoagulant and other materials present in the anticoagulant solution. And the least days of expiration is 21 days after donation, which is related to the time of anticoagulant as well. So we talk about this topic before or the last lecture. Rarely used except in certain situations. We are talking about the blood components. We are rarely used. So we don't use the whole blood in general to transfer to patients. So it is rarely used, but it can be used in some clinical indication or situations. It is limited. Its use is limited to the replacement of blood volume and the blood cell mass. When we are talking about replacement of blood volume, we are talking about hemorrhage, or we are talking about loss of large amount of blood due to accidents or surgery or whatever. So the situation is limited according to the situation. Traumas and massive surgical bleeding is an important situation that we need to transfuse whole blood to the patient. Why it is clinically limited use? So you have to think about this idea, why we shouldn't use whole blood in all situations. The second part of blood components is red blood cells. So the major type of component is red blood cells, and which is very important for blood transfusion. Why? Because it has an important part of the blood component that the patient need when we transfer or transfuse the blood to the patient. Red blood cells is the major source of hemoglobin and oxygen to the cells. So it is very important part of blood components. Red blood cells are indicated. Why we need red blood cells? We need red blood cells clinically to replace red cell mass. So when the patient has anemia or has a low of hemoglobin concentration, so he needs a replacement of red blood cell mass to increase this mass in his blood because he has anemia. Anemia means low amount of red blood cells. Maybe you have a reason of low red blood cells due to a disease or due to a destruction of RBCs. So the patient needs restoration of oxygen carrying capacity. The volume of red blood cells, when we are talking about red blood cells that patient need to replace red blood cell mass, we are talking a concentrated red blood cells. So we have to remove the plasma and all its components and constituents, and we have to concentrate the blood unit to have 250 to 300 ml of concentrated RBCs. So the hematocrit at this time, when we are concentrated the RBCs, should be around 75 plus minus 5% of RBCs in this unit. Adult hemoglobin raised by 1 gram per deciliter per 1 unit of packed RBCs. So when we use a packed RBCs unit and give it to a patient, we increase the hemoglobin percentage in his blood more 1 gram of his previous hemoglobin. So when we say that his hemoglobin is 9, if we give him packed 1 unit of packed RBCs, his blood will be raised to 10. And this is an experimental things that we measured and found during our clinical studies. When we talk about pediatrics, so the first thing about adults, we raised 1 gram per deciliter of hemoglobin per 1 unit of packed RBCs. But when you talk about pediatrics, pediatrics is related to the kilogram of weight of this pediatrics. When you talk about children and pediatrics, each 1 kilogram given 3 ml of transfused blood. And hemoglobin will be raised by 1 gram of deciliter per 1 unit of packed RBCs according to his weight. So the pediatrics we may give the pediatric or the child 50 ml of blood, 100 ml of blood, or whatever according to his weight. So the percentage is 3 ml per 1 kilogram of his weight. 3 ml of transfused blood. And we here talk about packed RBCs. Why we use red blood cells or packed red blood cells? Indication is chronic anemias and hemoglobinopathies. When we have chronic anemias or when we have when we have a problem in hemoglobin, we call it hemoglobinopathies. We are talking about the need of packed RBCs. RBCs can be used as fresh or can be used as stored in the blood units for the time which is proposed. We talk about 35 days of expiration date. We are talking about the blood preserved for 35 days to be given to the patient. As much as the red blood cells or the whole blood is fresh, which means that when we have a donation of blood like today, it is better to use it as soon as possible, and it will be a benefit for the patient. Because within the 35 days of expiration date, the blood unit will lose many components and the lifespan of all RBCs and cells, whatever, it will be depleted. And this is an important topic that we will talk about it later. Then another type of RBCs that can be used is the frozen red blood cells. So we can use fresh blood or we can use frozen red blood cells. This type of cells is not used in a wide ratio, but it can be used if there is a need for a rare red blood cells. Frozen red blood cells meaning long-term storage. So we can store RBCs for a long time until the need of use. And this is very important when we are talking about rare blood cells. But it is uncommon, but necessary in certain cases. As we said, uncommon, but we need it in some times. The storage temperature will be at minus 65 degrees centigrade. within 6 days of collection. So we have to freeze these cells, our red blood cells, as soon as we can before 6 days of collection. Freezing rate, we are transferring red blood cells to the freezer. Freezer meaning that we are going to freeze these RBCs. But this kind of freezing, it shouldn't be like a vigorously or in the first directly to jump to minus 65 degrees centigrade. But the freezing rate is 10 degrees C or 10 degrees centigrade per minute. Freezing at lower rate is very important. It will reduce the osmotic gradient. It will reduce the dehydration of cells. Quick freezing means ice crystals formation inside the RBCs, and it means cellular component will be destructed. How we can freeze RBCs? It is a long procedure that will be started with the use of cryoprotective agents. Cryoprotective. Cryo means cold. Protective means protection. So we have to use an agent which can protect RBCs from the coldness temperature. So the cryoprotective agent is an agent that can penetrate the RBCs and non-penetrating, which means that we have two types, which one can penetrate and the another one cannot be penetrating. The penetrating type is glycerol and dimethyl sulfoxide, which we call it DMSO. The non-penetrating is hydroxyethyl starch. So we have two types of cryoprotective agents, the glycerol and DMSO, which is used in general, and non-penetrating, it's the HES. Deglycerolization. So we use glycerol, but when we are going to use it again, we have to remove this glycerol from frozen cells, and will take a multi-step process of gradual washing with a series of decreasing osmolarity solution. So the point is we have to freeze for a time that will be stored for like 6 months, 1 year, 2 years. When we need this RBCs again, we have to deglycerolization of frozen cells by multi-step process of gradual washing. So we have to wash these RBCs with an osmolarity solution like saline. But we have to use a high concentration of saline for several times of washing with decreasing the osmolarity solution. So the concentration of the salt in the saline will be decreased gradually to remove the glycerol, which is penetrated the RBCs. So we will have rejuvenated RBCs, which is the cells that are treated with a solution containing pyruvate, inosine, adenine, and phosphate. So we have in the RBCs, which is frozen, we have glycerol, and we have the components that we use in the anticoagulant and the preservatives of solution that is present in the blood unit bag. So when we are going to rejuvenate meaning that we are we make the cells alive. They are alive when they are frozen, but they are like all biochemical reaction are stopped, but they are alive. So when we want to rejuvenate red cells, which means that we are returning them to the life. So solutions treated with a solution. Red cells will be treated with solution containing pyruvate, inosine, adenine, and phosphate. Rejuvenation time during storage or up to 3 days after expiry. During storage or up to 3 days after expiry. After their preparation, rejuvenated should be washed and used within 24 hours, during which time they should be stored. So we are talking about frozen RBCs that we need to rejuvenate them again. So we have to treat them with a solution containing pyruvate, inosine, adenine, phosphate, and we have to deglycerolization of frozen cells by using saline, and we have to use these cells within 24 hours. So if we need these cells, we have to prepare them and give them to the patient, but they have to be saved at 1 to 6 degrees centigrade. Red blood cells, another type of red blood cells is the neucytes. The neucytes are a typical term to the younger RBCs. RBCs have a lifespan of 90 to 120 days. But there is a young RBCs has a lifespan less than 60 days, which call it neucytes. We can prepare it by differential centrifugation of whole blood. Clinical indication, why we need it, for the treatment of thalassaemic patients, especially the young thalassaemic patients. And the patients that they need a blood transfusion frequently as thalassaemic patients. And why we need them? Because the red blood cells, which we call it conventional RBCs, has high iron contents. So those patients like use blood or blood transfusion very frequently, which is related to the type of anemia that they have. So the use of many times of blood transfusion means that there is a lot of iron in their blood, and this iron can be deposited in blood cells and blood tissues and causes a situation called hemosiderosis. So when we use a neucyte transfusion, we are using red blood cells, which is neucytes, to those patients to reduce the hemosiderosis, to reduce and to raise the hemoglobin level. Another kind of blood component is the fresh frozen plasma. Fresh frozen plasma, fresh meaning fresh. Frozen is a frozen. Plasma is the type of component which is present in the whole blood. So we are going to freeze the plasma from the whole blood, and we have to freeze it directly after the donation. So we must prepare, after the donation, we must prepare and freeze the plasma and separate it from other blood components within 8 hours of collection. And we can say that you have to separate the plasma within, like, as soon as possible. And we usually separate the plasma like within 1 hour of donation. But in general, you can do that within 8 hours of collection. The fresh frozen plasma can be expired after 12 months of storage at -18 degrees centigrade or 24 hours once thawed. Like, you can store this plasma, which we call it fresh frozen plasma, in the freezer at -18 degrees for 20 and use it and thaw it within 24 hours of thawing. Like, when you need a fresh frozen plasma for a patient, you have to remove from the freezer, thaw it in a water bath, and you can use it within 24 hours once thawed. You thawed, and then you have to put it in the refrigerator at 1 to 6 degrees, and you have to use it within 24 hours of thawing. If you are not using, you can't put it back in the freezer. Must be thawed, immediately used. If not used immediately, store it at 1 to 6 degrees centigrade and use it within 24 hours. Fresh frozen plasma has this name because it contains all coagulation factors. And this is why we have to remove or separate the plasma from the whole blood immediately after the blood donation or within 8 hours. Why? Because we need to save all blood components except the cells. The fresh frozen plasma may contain the coagulation factors, albumin, the globulins, water, electrolytes, whatever present in the blood will be saved at this moment because it will be frozen and saved for 1 year. Why we need fresh frozen plasma? Indication include coagulopathy due to liver disease, disseminated intravascular coagulation, and we are talking about disseminated, which means like dangerous intravascular coagulation processes, congenital factor deficiency, which means like hereditary deficiency of coagulation proteins, or elevated prothrombin time and partial thromboplastin time. And this is a kind of test that we do for a patient. If the patient has elevated prothrombin time or partial thromboplastin time, he needs like a fresh frozen plasma. Shouldn't be used as a volume replacement. In general, we shouldn't use the fresh frozen plasma for a volume replacement. Volume replacement means that the patient has lost a lot of volume of blood, and this blood or like fluid should be replaced. So we use the fresh frozen plasma when we have a problem in coagulation proteins, but we can use it as a replacement of fluid. But as a general, we don't have to use as a replacement of fluid alone. But we can use it with the whole blood, or we can use it with the backed RBCs. It depends about how the physician or the doctor asks for. We can also we found also the platelets in the whole blood, and the platelet can be concentrated as well and used as a platelet concentrate. Concentrate means that we are concentrating the platelets in the one blood unit, and this process can be done by by ultracentrifugation, and we use a special process and incubators and the agitation process to keep the platelets alive for a long time. The platelets can be used as a concentrate when we have platelets aggregates. So the platelets in general, they aggregated when we separate, but we have to keep them and store them continuously with genital agitation. So when we separate the platelet concentrate, we have to remove these kind of cells in one bag and put them on an instrument which is like we call agitated incubator at 20 to 24 degrees centigrade and continuously agitated and we can concentrate the platelets in this bag up to 5.5 to multiply by 10 to 10 platelets in one bag and give it to a patient. Why the patient need platelets as a concentrate platelets? It can be used for severe thrombocytopenia. The patient who has like severe deficiency of platelets he needs a platelets. So they give them platelets as a concentrate. A bleeding patient in surgeries or traumas. And as well in surgeries or traumas, there's some kind of bleeding may happen to the patient and they need a concentrate of platelets. Thrombocytopathy. We have another condition called thrombocytopathy as well, is can be resolved by giving the patient a platelet concentrate. Another kind of blood components is called the cryo precipitate. Cryo precipitate is a kind of coagulation factor that we can separate from the blood or the whole blood and use it as a concentrate for patients that they need. The most important component of the cryoprecipitate is factor 9, and we have another factor is called von Willebrand factor, has like 50%, 80 unit can be found of factor 9, and 50% of Willebrand factor, and fibrinogen like 200 milligram, and factor 10, which we can find like 25% of factor 10. Cryoprecipitate is a kind of blood component that have all these components. We have to store this kind of cryoprecipitate after preparation at minus 18 degrees centigrade, and it can be stored for 1 year. Before transfusion, it should be thawed at 37 degrees and stored at 1 to 6 degrees centigrade. Why we use this kind of cryoprecipitate? We use it for severe von Willebrand disease, severe hemophilias, and hypofibrinogen. So we use the cryoprecipitate in these cases because the cryoprecipitate has a concentrated amount of these components which can be used for those patients that they need. We have another kind of plasma other than the fresh frozen. We have plasma derivatives. The plasma derivatives is prepared from the fractionation of plasma pools. Concentrates are processed to purify and inactivate viruses. So we can separate the plasma and we can use it by ultracentrifugation. We have a big centrifuge special for the blood units, and we can separate the plasma and we can pull it and concentrate it and use it for patient. Indication for use include factor 9 hemophilia A and factor 10 hemophilia B or Christmas disease, immunoglobulins, which we call immunosuppressed patients who has a problem in immunoglobulin level, autoimmune hemolytic anemia, human albumin volume expanders, and we can use it as a volume expanders for people who has a deficiency of albumin. So we reach the last slide of our chapter, which is like an instruction for donor education sheet, and you can read it here and you can verify all important information that the donor should know about the donation process. Thank you very much, and we are we will meet in another lecture next week. Thank you.